Well, thank you, Dr. Phelps. So good morning, good afternoon, everybody. Hope all is doing well. Exciting week, almost more than halfway, so almost done.
Next week, Wednesday, this group is done on Wednesday. So yeah, just half a week to go.
Well, the material has been quick. It's nice to have. It's less intense than usual exams. Kind of quick after Thanksgiving, so hopefully it's and I know about the extra credit. But yeah, good afternoon, everybody. I am here. I think I'm here to talk about my headache therapeutic lectures. I'm happy to take any questions. We had times to discuss. We had a good discussion in class, but if anybody had any questions as they were reviewing the materials, I'm happy to take them. And as you can, I will go through the slides and just give you a quick summary of what did we talk about and what were the things that we emphasized on that are important to know um, um, for just as an initial management of migraine and preventions of migraine headaches.
If there are questions from the Owen classroom, we can't hear them.
So apparently no questions from Corvallis.
Yeah,
From Owen? Yeah.
are there no questions from Owen so far? Okay.
No
Any
questions from Owen.
questions
So
from yeah. I'll
then then I can do a quick summary of the key take points that we discussed and the final slides in the lecture. So as the goal is that Dr. Ishmael focused on the pathophysiology, the diagnostics, the morbidity, of headaches in general. We discussed in my lecture as mostly on the therapeutics and how migraine is approached as both in hospital and as outpatient. Very important rather than to recognize the symptomology is for me is more important is that you have your treatment approach to differentiate between abortive treatment and preventive treatment, two different modes of treatments and two different philosophies, and both are applied. In the abortive phase, you have different medications than your preventive medications. Do notice the differences between the triptans, especially when it comes to their metabolism, with respect to which ones are used by the MAO enzymes and which one are CYP enzymes. This difference, we talked about the importance of the interactions with SSRIs, the importance of spacing it between ergotamine. There should not be any scenario where you can give a triptan followed by an ergotamine within 24 hours due to vasoconstrictions, as we mentioned. In the abortive therapy, also recognize the different routes of administration for these triptans, specifically for sumatriptan being a favored agent in the hospital because it's the only one, it's subcutaneous, so you can inject it. And that provides you with a quick onset of action, and that's the goal of the abortive treatment. The role of antiemetics in your abortive treatment focus that we talked about, they must be parenterals. 70% of the acute migraine attacks that presents to the hospitals have a lot of nausea. So giving an oral antiemetic is not the most useful strategy. specifically that injectable antiemetics, we said, have an analgesic effect that complements the effects of the triptans. That's why they're pursued. And specifically of these antiemetics are the antipsychotics ones, or the ones that have antipsychotics properties like chlorpromazine and prochlorperazine. When you give these, you should remember that these are antipsychotics. These are first generation antipsychotics, so you need to monitor the heart rate, and you worry about extrapyramidal side effects. Those are the dystonias, those are the akaphasia, so your sudden contractions of the neck muscles, the oculogyric reflex, the neck rolling backwards, all of these are form of dystonias. And we said that in the protocol, we call it the migraine cocktail, diphenhydramine is administered with these antipsychotics to mitigate the dystonia effect by effect of anticholinergics. Then we talked about the new drugs. So the new drugs are the GPANs. These are small molecules, CGRP. These were approved in 2019, 2020, and there was one either this year or last year. The key with these, what's the catch for these drugs, is that they have they are designed to lack that that's cardiac vasoconstriction. So they lack the cardiac safety which triptan has. Another drug we talked about is called lesbiditan, and also this one is also got approved in 2019. The same point like the GPANT, it doesn't have vasoconstriction, which makes it very safe in cardiac patients, in which the advanced form of these cardiac patients cannot take triptans due to vasoconstrictions. That's all about abortive therapy. As for preventive therapy, we talked about the criteria. It's not, despite that the criteria tell you it's, I don't know, 2 attacks. It's not just quantity of attacks, it's also quality of attacks. So severe pain, even a single attack with severe pain, patient can elect to be offered preventive therapy. And the drugs that we use here are chronic, are every day. And when we say chronic, it gives the impression for patient that this is a point we talked about it in class, it gives the impression that this is lifelong. The keys, the language used now when you are talking about these medications is that let's try them for 6 months or 1 year and let's evaluate. So it's nothing, everything. Although the key for migraine or the prevention, it takes on the approach, the chronic philosophy when treated. So for medications, in slide number 23, there is, we talked about almost any medication you can think of has been investigated for migraine prevention. So if we talk about evidence-based here, we're going to have to, talk about tables of 100+ medications. However, what we have summarized in the lectures are the one that's used in practice who have some kind of an evidence, which mostly observational studies. These are the beta blockers, the calcium channel blockers, specifically verapamil. And we talked about the psychiatric medications, so your venlafaxine, your SNRIs. You said about SSRIs have no role in migraine, though SNRI has. So does tricyclic antidepressants. Or be careful of the side effects of TCAs. And other than that, the new molecules, so you got your CGRP monoclonal antibodies. These are the injectable ones. You can differentiate the monoclonal CGRPs being injectables and the oral CGRP, the GPANs, are being, well, oral medications. These are small molecules, so you can give them orally. We talked about these GPANs as a preventive medication. So the CGRP, the monoclonals, and the orals are investigated for. In fact, the monoclonals are approved for migraine prevention. Very safe drugs, expensive, yes, because it's about $700. Again, the cost is just as a summary, as an FYI, rather than a reminder to memorize it. So $700 per injecting, very costly medication, yet safe and effective. They were approved in the last 3 years, so long-term data are still lacking, but are encouraging based on the what gets published in conferences. Finally, we talked about the cluster headache. So quick, the introduction about cluster headache. For my questions, you're not gonna do diagnostics yet. You have to recognize the symptoms, and I think Dr. Ishmael had it in her slides, the full cluster headache, and she had a slide differentiating cluster from migraine from tension headache. For cluster headache, presentation is key, very different, presents very differently from migraine. Treatment, the oxygen is very important, oxygenation of the brain. Even if your patient is not hypoxic, cluster headaches get treated with triptans as well as oxygen via face mask. And for items for prevention, you have your verapamil and lithium. I didn't talk much about lithium, though it's been covered for bipolar. I'm not gonna ask you about the detailed information about lithium, but you should, if you studied lithium, you should be familiar with not the dose, but at least the target serum level for lithium, which, as we mentioned, is, if you want to remember, it is almost like serum creatinine, 0.8 to 1.2, and that's something almost all of you future pharmacists know, serum creatinine. So associate lithium with it, and you should remember serum lithium levels. Again, I had take home kind of a summary in the end, but I hope this summary was you find this summary helpful, and maybe now you can think of new questions if you didn't have 10 minutes ago. What makes verapamil a better option than other CCBs? Greater vasodilation? No, in fact, verapamil has the least vasodilations of all the CCBs. You can argue that even a vasodilation is not something may be desired on migraine, or I should say that was the theory about 5 years ago, when it was all about vasodilation and preventing that vasodilation. But no, that it has not to do with vasodilation. What does it have to do? It was just the studies, really. Diltiazem did not have, so that amlodipine, none of the CCBs, amlodipine was not statistically significant than placebo. Diltiazem was marginally better than placebo. Verapamil had, even when you read the studies about verapamil, you'll find it confusing. Really, the route where verapamil is being favored is by practice more than evidence. Now, the evidence tells you verapamil works. It's mostly practice, and you see a lot of providers feel very comfortable. Especially, it's safer to take long-term than a beta blocker, which can cause depression and sexual dysfunction, and that's unpleasant to live with for a relatively disease of the early adulthood. So verapamil works because it just works. Sorry, there is no pharmacological explanation why it works. It's just by reality and as well as some evidence. Amlodipine doesn't work at all, and diltiazem a bit classic, yeah. But when you do as a provider, is that we don't like to say, we just try to make it sound convincing. But if a patient asks you that question, yeah, you're gonna be like, it's $5 worth for saying it is what it is. Any other questions? Dr. Phelps, are we waiting for Dr. Ishmael as well to join?
Yes, Dr. Ishmael is going to join. I gather she's not in the Owen classroom yet. While we're waiting, if there's no more questions for Dr. Al-Jamali, we can probably let him go. Going once. Going twice. All right. I think, thank you so much for coming.
Thank you, Dr. Phelps, giving me the chance.
Wait, we've got one that came into the chat.
See, saving the best for last. Do you know what medication is commonly used for preventive therapy right now if patients don't have comorbidities? Basically, it's up to so if the patient has no comorbidities, this is going to be based on what the patient desires and based on what the providers is gonna prescribe. In this case, you would give the option to the patient that you have CCBs. Remember that beta blockers and CCBs don't hurt the patient if they have no cardiovascular disease. That bradycardia from specifically beta blockers more than CCBs. Beta bradycardias, the effect of bradycardia is more pronounced at the heart or the more sick the heart is. So even if you get that's why we can give beta blockers for headache preventions. You can give them for anxieties. You can give them for even social anxieties if somebody's take a presentation. So you give the patients option to choose from, and based on what the insurance, most of these medications are cheap and generic, so cost is not going to be a major issue. But maybe the CGRP, maybe the patient say, hey, I saw the ad and I want the small molecule or the CGRP. Now this is going to be an insurance barrier here. They have to try the beta blocker. I think now it's not their tier 2, maybe they're not at tier 1. So I don't know what was the formulary. So yeah, based on what's the insurance formulary, what's the patients decide on. It's mostly risk benefits of side effects and efficacy, and it's going to be one of the either beta blocker, a verapamil, a venlafaxine, or if they have tried many of these before or have contraindication, they may try if their insurance let them, they go toward the monoclonal ones. Thank you. Any other questions? Well, if there are no more questions, thank you, Dr. Phelps, again for giving me the chance to teach my beloved lectures, and good luck, everybody. It's been a great pleasure. Thank you for your questions. It's been a pleasure, and look forward to see you. Well, we won't see each other until fall and P3 year. So hope to see you by then. In the meantime, stay safe and please email me if you have any questions. On your P3 or anything related pharmacy, I'm happy to help you. Thank you and good luck.
Thank you.
Thank you.
I think I see Dr. Ishmael coming into the classroom, so.
Thank you, Dr. Phelps.
Have a good day.
Oh, yes, I'm here now. Sorry, just really from the meeting. But I think we're still going. All right.
Dr. Ishmael, if you want to take it from here, I'm gonna leave you to it.
Thank you.
All right, thank you. And I'll see everybody Monday. And no one is asked, but I will just share it. The exam is all multiple choice. So bye-bye.
Bye. Hi everyone. Thank you. Oh, brilliant. Thank you. Looks like I have some questions in the. Oh, sorry. Okay. Hi everyone, I can see a message in the chat about preventative therapy. And to be honest, I don't have a really good answer to this. And my understanding is that the discussion would go, do you want to take something to try and prevent headaches? Some people might be opposed to that. Some people might try dietary or lifestyle changes, you know, making sure you get, there might be non-pharmacologic interventions, but then if you enter the realm of pharmacology, I believe that the strategy, you might have a favorite that the neurologist would consider, but really the rationale between groups, you're more likely to try and start on one, give it some time, and then move to a completely different mechanism. I can't really see much logic. So maybe someone in therapeutics would have a different view, but the rationale for why choosing one over the other is probably going to be related to side effect profile and just how bad migraine headaches are and how motivated somebody is to want to take another prescription medication. But the key thing is to remember the goal is very different, that there are very large classes of different, all with different underlying mechanisms of action, but efficacy is measured if it's greater than 50%, then it can be tried as something for prophylaxis for migraine. In theory, these, Botox has been an FDA-approved strategy for prophylaxis of migraine, longer than the CGRP drugs. So, but now I believe these CGRP antibodies are still quite expensive. So, whether or not in a few years' time, you know, as you're after you've graduated, whether we're going to see a massive change with those being tried first, but certainly something like straightforward, like propranolol, a cheap thing to try. But again, individual patients might have a different experience just based on going through this list of very different mechanisms. So it seems like a messy answer, but really no, I think it'll just be a conversation between the patient and the prescriber and just trying to see if they actually work for that individual, because most of the time it's idiopathic, you don't know what to start at it, and it's just a strategy to try and prevent or reduce severity, frequency, or duration. So how many days you have lost every month for headaches. So, and sometimes diet, lifestyle changes, realizing what your triggers are sufficient, and just having someone extra help in managing that might be sufficient to act as prophylaxis instead of actually starting to take a new medication. So hopefully, yeah, it's a interesting subject, but you can see that it is, it's a big area of unmet need, and that's why we do have this kind of pharmacology of prophylaxis and the pharmacology of acute or abortive treatment, and really expanding. You know, it's a lot of drugs for 2 or 3 hours of lecture, but it's getting a bigger topic. Yeah, so hopefully that helps. Yeah. And then I can see Ian, was that answered earlier? Okay, great. I was thinking, yeah. Thank you. Feel free to speak up or put a message in the chat. I'll just I think we decided because I ran out of time, really, because headache has expanded. So we talked a lot about the headache packet, and then we went up to smoking cessation, nicotine, and along the way we covered some concepts. I'm just going to ramble until anyone else thinks of a question. We tried to use that as a way to think again about your projection neurons and how neurons work. And then along the way, in terms of pharmacology, we've had to talk a little bit about full agonists, partial agonists, antagonists which have no intrinsic activity at all, and then you know what that mechanism means really, and we use that to think about the idea of a partial agonist being a huge breakthrough in smoking cessation. And so those are, I would say, those are kind of principles of pharmacology that you've sort of taken with you throughout the whole, you know, back to last year too. But my I've gone through it about 3 times to make sure there is no direct question of anything, you know, about the other topics after that. But we did use, in terms of talking about ADHD, we had to think about the mechanism of action of cocaine as a classic stimulant, which has abuse liability, and also the idea that cocaine is a non-transported inhibitor, which essentially is what the SSRIs and SNRIs are too. Those things you've been talking about, technically, it would be what we call them. They don't really get inside the presynaptic neuron. They're working on the outside. And that's a little bit, well, it is fundamentally different in the model that has been adopted, in that the amphetamine-like substances are what we call transported inhibitors of that protein, of the dopamine transporter. So they actually go inside the presynaptic neuron, and that is interfering with the vesicle, the vesicular storage. The vesicles are leaking, they can't concentrate the transmitter. And so now we actually accumulate dopamine in the cytoplasm, if you just start to think about location and where these things are. And it can be such an extent that it starts to cause a reverse transport. So dopamine's leaking out the wrong way through the dopamine transporter. So you still end up with an increase in dopamine at the end. And that's why there's abuse liability. But the fundamental difference, what the new information I introduced was the idea of a transported inhibitor versus a non-transported inhibitor, and that those have not terms you're going to hear of much, but we already have a framework. So if there are new things that come along, this is where we've landed on the correct terminology. And I think up until now, that would not have been presented in any of the pharmacology. Like, sorry, talking at the computer, I don't know where. Yeah, so hopefully that helps. With the different mechanism of action. And the site of action of those stimulants is going to be ideally the prefrontal cortex, or areas of the brain where we know there's this is where there's a help in paying attention, learning. The studies say that if the individuals with a diagnosis of ADHD will show improved outcomes with this class of drugs if used appropriately. And that's why we have the stimulants for ADHD as quite an important class, and many, many variations of them in terms of how they're delivered and the pharmacokinetics, but just the basic mechanism of action is pretty straightforward. Of course, I don't have any, for me, my task is to make sure you're familiar with the pharmacology, the mechanism of action. So don't be put off. Those tables are there for your own interest and to apply that pharmacology in a therapeutic setting so that you know it. But my questions aren't about the therapeutics, so that if you see something that says ER or extended release, or you know why there are so many variations, but the basic mechanism of action is that they are non-transported inhibitors, and they stimulate this, basically the class of stimulants. Great.
I think there's a question in the chat.
Oh, is there? Oh, a new one. Oh, I need to scroll down. Thank you. Hemiplegia and the surprise at the same time. Oh, right. So the first question is about hemiplegic migraine. So yes, my understanding is that it actually is part of the aura, but the paralysis can last. And I think this will vary with individuals. So the person I sometimes it's just you're having a direct conversation with someone that suffers from it, and they might present in a different way, but it's supposedly part of the aura. But once the paralysis sets in, that becomes a very defining factor, because the paralysis might last, or the weakness could for days. So it should be reversible, but that individual is going to be basically at home maybe for a week with a headache as well. But my understanding is that it actually begins with the aura. They can tell that something's going to happen, but that aura is it will carry on. The aura is atypical, and but I think depending on, which mutation you have, or how that change sort of penetrates, I think people's responses to those mutations can be quite different. But basically, it is an aura characterized by extreme reversible paralysis, and usually helped with a calcium channel blocker. And these were the individuals that really gave us the idea that there could be, in some cases, a channelopathy that's responsible for migraines. And it helps us understand atypical complex migraines where people have a stroke-like syndrome. So hopefully that helps. And then in the slide of reverse transport, does the dopamine go out using the same dopamine? Really, I would think of it as we're drawing these visual aids just to imagine what that looks like. The answer is yes. It's the same protein that's packed in the presynaptic membrane. You would think that if you've had a blast of an amphetamine, that might be somewhat dependent on, the amphetamine-like drug is going to be there for a certain amount of time, and then it'll have dosing end effects, whereas the dopamine is always going to be there. So you might have you've really got compromised transporters, because the amphetamine is being taken in, and I'm sure people are studying this, but it is the same protein. So you could have proteins that are taking up the amphetamine, and then eventually the transport is all in the other direction. So yes, it's the same protein, but there might be might be related to the dosing of the drug. And then, at any one time, you might see influx of amphetamines sort of winning, but as that'll only occur for a small amount of time once it's all, and then mostly it'll change direction, and you've got dopamine coming out in the wrong. You've got it trying to be taken up, but also leaving if the concentration in the cytoplasm has got too great. But eventually you will have this sort of reserpine-like depletion. You're going to deplete your neurotransmitter. And of course, de novo synthesis of the transmitter will not be able to keep up. So it's going to be, that's why amphetamines in general, you can have a real down, or just the effect of taking those kinds of drugs. You can definitely have a sort of washing out, feeling lethargic. Dopaminergic transmission is going to be hard. We know that neurotransmitter, the chemistry or the biochemistry of that is that we do rely on reuptake really heavily, because we can't synthesize the transmitter itself. We can't. So you've got a situation that's it's not going to feel great. The after effects of certainly if you think of people abusing methamphetamine, you're certainly going to feel very. You'll get to a situation where the neurons just can't store enough or can't keep up, and so you'll compromise your general neurochemistry, really. But it's the same protein, and those figures are just meant to try and help visualize what might be happening. And really, that one is good in the text, because it shows you just how different it is than something like cocaine. So normally, if the plasma membrane's intact, you wouldn't believe or wouldn't expect your SSRIs to get inside the neuron. The site of action is on the outside. So that's why we do try to bring in membrane topology and think of structural information that helps us visualize in more detail what these proteins, these integral membrane proteins look like, because it can help us bring the models a bit more, make them a little bit more realistic and try and work out where things are in relation to everything else when you've got the plasma membrane being such a specialized barrier to keep things on either side, really. So I think that's kind of brings a bit of cell biology into it as well, so that it's a bit more of you can visualize how it works. And for me, I think that's so important because, as I've said, there are lots of people telling you we can't teach you every drug, but if you can think of a pattern, it's a lot easier if you can think of the logic behind it. That makes you better prepared going forward when we do have new things coming onto the market. Hopefully in 10 years we'll get better at treating some of these things, and there will be new mechanisms and new things. So I think thinking of it in real life, how it actually works, without trying to, you could delve into the fine details of hopefully somebody else is working on that and we'll get better models and we can use the working model we have for now to understand what you're actually dealing with on the front line of helping patients, really. And that's the great thing about your role. You're really there and you're going to see the breakthroughs, but also fall back on the trusted things that do work. Yeah.
I think you mentioned the unequal tolerance. Explain that concept today.
Unequal to, oh, right. In the, yes, I think it actually relates. I think we use that same slide. Sorry, I know the slides are here somewhere. I'll just pull it up. This was really to help you. I'm not sure if you touched on this in pain, but we talked about 3 different kinds of tolerance. Classic tolerance, which is where you have a shift in the dose response curve to the right. And this is the classic effect that happens with opioids and to some extent benzodiazepines. And this is why they're not. So actually, we've seen this before and we did discuss it, but it's shown again on slide 39. The idea of oh, right. Sorry. Thank you. Sorry, I know you did pull it up. Sorry. Thank you. The last. Perfect. Yeah, thank you. Yeah, sorry. Hopefully everyone can see that. Yeah, so this we've seen before, and it just happens to be on this slide. But it was this is the idea of classic tolerance, where you've got a shift in the dose response curve to the right, versus the concept that some drugs of abuse can cause a sensitization, where you become more sensitive to it, and that's a shift. Or reverse tolerance, it's sometimes called, which is essentially a sensitization. And we also just mentioned the idea of cross tolerance, where you can be exposed to a drug of the same mechanism and you don't necessarily have to have been. So if you're already sensed or tolerant to opioids, you don't have to be maybe exposed to heroin to become also tolerant to fentanyl, if you like. So if it's within the same class, the drugs will produce the same kind of effect. What we've talked about before is the reason that opioids are so dangerous is that if you think of the region, and this does help illustrate the main concept, think about when a drug's used, where is the site of action? So for ADHD, we're hoping to target the prefrontal cortex. This slide shows you that there's unequal tolerance to some of these effects. And so with opioids, the areas of the brain which are used to, where you're wanting to invoke an analgesic effect, the pain pathways are in a different part of the brain than those that are responsible for reward. So we said the reward pathway are the dopaminergic neurons that go from the ventral tegmental area to the nucleus accumbens. That is our reward pathway. So tolerance to pain as a response versus reward as a response versus to the breathing aspects of opioid, it can be unequal. And that, I think the question was about unequal tolerance. And this is what makes the concept of tolerance, we care about it a lot because it makes mu opioid receptor agonists very dangerous, potentially if people have become tolerant and are seeking the rewarding effects. You have to take more and more, but because you might have become tolerant to the rewarding effects or the analgesic effects, but you're not tolerant to the signaling that allows you to breathe. And so tolerance as a basic pharmacological concept is illustrated really well in with this class. So it's mu opioid receptor agonists are associated with classic tolerance, and this helps us understand why they are so dangerous. And to be honest, it's understanding this neurochemistry which has probably helped the messaging behind the use of an antagonist, and why this is. It's now we've got much better, still got work to do, but better access to the antidote, if you like, to block something with no intrinsic activity. Yeah, so we've talked, tolerance has come in a lot in terms of managing pain, drug addiction, and this classic that over time, the naive patient is the black solid line, but over time we know that there will be tolerance. And the concept of cross tolerance just means you don't have to have been exposed to. So you'll see that also in, we didn't get to this, so don't worry, but I know you've perhaps talked about psilocybin from other people, but 5-HT receptor activity, there's also cross tolerance between some of these natural products as well. So if you desire a 5-HT serotonin agonist, you will probably seek and feel you could take other 5-HT receptor agonists and seek those and feel the rewarding effects. Similarly, if you are sort of chemically addicted to a mu opioid receptor agonist, you might desire or crave those first because it's the same mechanism. Now, that can be all out the window when people don't have access to that. So then we'll try other things because we've talked about the fact that the rewarding of pathway is somewhat central, that everything ends at the nucleus accumbens here. So something is changing. Many different mechanisms change signaling in that area. So that's why people could try cocaine because they couldn't get something else, because it is looking for that high. But sorry, probably carrying on too long. Yeah, just jump in if there's more questions. I don't know if it's helpful. Yeah.
Could you say more about sensitization? It seems kind of paradoxical, like in relating to tolerance.
It is, yeah. It's not easily explained. I think we can understand tolerance if you think back to sometimes you could be tolerant to an agonist just simply by removing the receptor in the target area. And so classic tolerance to due to downregulation of receptor is sort of a logical way to think of tolerance. You could also become tolerance can be indirect because your metabolism has changed. The sensitization is a little bit harder to work out what the neural mechanism is, but this has been put forward as to why, in terms of a managed detoxification, it's so important to manage it, because as you're allowing, complete withdrawal is usually very dangerous. And so this managing of it over weeks and a slow titration, even in smoking cessation, you want to titrating the use of the drug with the with something like Chantix, it's a time, you need time. And if you think back to our idea of drug holidays or allowing that neurochemistry to reset, because all drugs do are to change your endogenous signaling. I think that it's not like a light switch. There's so many compensatory built-in mechanisms because the wiring is so complicated that unfortunately we don't have great models for sensitization, but this has been put forward as to why withdrawal, things like cocaine and some of these others seem to make people, there's probably a map of sensitization in brain areas that we could draw for cocaine or something like that, or you know, MDMA, methamphetamines. Those are the ones that it's very hard for people to know where they're up to in terms of trying to abstain or trying to, and that's why a pill or something you don't know where the origin is, it's actually much more potent than you thought it was. You don't really know where you are on this dose response curve and also where you have physiologically changed. I think that's probably the most important thing, that certainly how anything where you habitually crave and are obsessively over time taking on this exogenous substance, you're not going to stay the same. And so with all of the drugs, but we try and look at the ones that cause classic tolerance and then acknowledge that that doesn't work for them all. Some of them you actually get a heightened, your physiological response is, you're actually more sensitive, but still not craving, or not, it's not satisfying the craving. And so you keep taking it or look for better stuff, more pure, and maybe that stuff isn't pure. It's sort of, we're stepping over into the illegal aspects of it, and even that's complicated in Oregon because we've got decriminalization of small amounts of some of these Schedule I controlled substances. So, but I think probably we could draw this kind of map. This has really helped. I think of it as the different geographical areas of the brain are unequal in their responses, and we know it best for, so this is drawing for mu opioid receptor agonists, and this will be the green response on this diagram. Or non-analgesic, yeah. And this is where such a shame, because some of these are often coming from natural products. They've given us such insight into the potential, but we've not been able to separate abuse liability from their desired therapeutic effects. So we like to think of therapeutic indexes, not, well, in terms of side effect profile, but actually a lot of these natural products that are drugs of abuse have a low therapeutic index or need management. And it's fine as long as we manage it and realize what's happening. Because there is the danger you'll go too far the other way, and now so much reluctance to withhold opioids when these are still, you really need them if you've just had major surgery or you've just had, so we have to keep them at the table, but manage the risk, I think. And even, yeah, so I think we're in a better place with more controls, but I think it's something you're going to hear about for the rest of your working at Purdue Pharma and the different strategies, and to understand what else could we do to manage the abuse liability. Sorry, shall I stop sharing, just make sure there's no things in the chat? Yeah, and you can always send me an email over the weekend. Oh, calcium channel blocker. I do believe, yes, so there's a question in the chat about hemiplegic migraine, and I believe that those individuals probably, so as a class, we do have a lot of calcium channel blockers that have been developed and a relatively safe class that are used for treating other things. So those individuals will probably taking some maintenance dose if you have a history of it. And in that case, we know probably what is the cause. So I believe, yes, they do work as preventative for those patients. Will this slide be on? Was that the slide about tolerance? So I think I talked about tolerance as, if you remember the beginning of that drug abuse section, we talked about the three, as general principles, the three phenomena that happen just to refer to the pathways, and so slide 16, we talked about the concept of tolerance. I just had the slide later on, but I think it's a slide you've seen before. We've drawn similar pictures that I'm showing it in words there, but really the idea is a shift in the dose response curve to the right. So the picture I just brought up illustrates the concept of tolerance that's described there. But no, I don't have, everything's more pharmacological, you know. I think my questions aren't related to, there's questions about agonists, antagonists, basic principles, but we didn't go into specifics of alcohol or marijuana or cocaine comes back again later, but we kind of covered cocaine to illustrate ADHD. Yeah. So hopefully that helps. Yes, so we really covered in detail smoking cessation. There's a question in the chat about slide 23. Yeah. Yeah, and I didn't get to tell you about the Mellanby effect. Yeah, so slide 23, and so there'll be general pharmacology questions, but the actual details of the material go through slide 23.
Are there treatments for hemiplegic migraine besides CTB? So like what's first line?
You know, I'm not really, it's funny, I used to talk about it more, but now there's so many other things I think in theory, they probably have access to all the migraine treatments because it really is a kind of migraine. It's just that for them, the migraine specific treatments will not help their paralysis. If you think of it that way, because it's the aura that's so unusual, that it actually is a paralysis, but reversible. It's so the calcium channel antagonists to try and prevent, but then if you do have one emerging, I believe they still have access to everything else. It's their preventative, and their migraine will look different. And sometimes the paralysis goes along with it. It's going to spill into the painful part, or just an unusual kind of primary headache disorder. But definitely linked to a familial component and given us. And then we talked about the 4 phases, the events leading up to it. The aura is really phase 2. And we believe that whether or not you perceive your aura or not, this is why we're seeing most things. We don't see a distinction in prescribing things, whether you've got aura or not, because we believe the underlying basis of the aura is probably the same. It's this cortical spreading depression and a wave of excitation and then depolarization that along the way keeps the trigeminal nerve activated. And then phase 3 is the painful part, but because the trigeminal nerve projects to areas of the brain which also drive feelings of nausea and sensitivity to light and sound, because of the complexity of that large cranial nerve, that's why you'll say that you'll see all these acute or all these new drugs. They'll say it does not only does it take away your pain, it'll take away your associated symptoms, with the caveat that the associated symptoms are if you feel nausea, photophobia, or phonophobia. So because that is the trigeminal nerve activation part of it. the aura precedes that, and we believe that's because, and that's what's starting to engage the trigeminal nerve. But the aura is very different because that's a different wave of excitation, and then depression so cortical spreading depression is the aura. But some people might not be bothered by an aura. They just don't, it's probably going on, but they don't realize. Yeah, the International Headache Society is always classed. One of the first things you'll be at, do you have an aura or not? Because if you do have an aura, that can help you start. You should really take your sumatriptan or your new drug straight away, as soon as you know, because maybe you can stop the pain. You've got about an hour or two to stop it. And sometimes people, when they start to get headaches for the first time, they might have all the aura, but it might never get that far. It might just start be practicing. And then, you know, I think, oh, yeah, I probably was having a headache, or is the beginning, the pain then starts to follow more of a pattern. And so that's why it will seem a little bit like the seizures, where people's seizures will start to follow a pattern. And what you're trying to do is make sure they don't get worse. You recognize the pattern, and hope a pattern will start to emerge, usually with these things, and that helps you work out why. Please, you should take this as soon as you realize it. Don't wait for the pain, because you've got much more of a chance of stopping the pain and making it closing that signaling down before it starts to just get really so incapacitating. Yeah, I always try to be straightforward on questions. So usually people with my questions, unless I've made a mistake in the question, I don't think I have, just don't try and overthink it. Usually I'm just trying to ask you straightforward things. And most people, if they miss my questions, it's because you've all studied and you brought so much to the table in answering it. But really just try and, if I'm thinking the basics that I want you to be able to remember without having to look at my notes again, take forward with you. I'm usually trying to ask you something that's maybe more straightforward than the details with the very fine details. So that's usually how people get tripped up on my part, usually. But I'm not saying you will, but don't try and overthink. Usually I'm trying to ask you it in a straightforward way. And then if something is confusing, write it at the front, because we always give partial credit, or realize if something's confusing, give more than one right answer. If you do they get oh yes, so there's a question about ADHD medication. Yeah, it's really interesting. It's an area, so for that specific ADHD, there I think maybe it's a really interesting and a diverse set of people. So you can imagine some people probably are using it to feel a high. Some people might be seeking it because there's a lot of pressure for performance enhancement. Maybe that might be in terms of because they make you alert and stimulate you and make you feel so without an ADHD diagnosis, they definitely, so it could be, to be able to power through or stay up or concentrate on something to the exclusion of all other things. So the people who seek out and try and buy, divert or seek those particular tablets are more to, it can be really different. I think if you're going to crush it and snort it, that might be a different way, because you're trying to avoid the kind of slow bioavailability. But some people just might want to take them because there's something coming up that they need to be alert, stay attentive. They want a boost. They can't afford to be too tired. So people might seek those for different reasons. And I think there's a lot of research about that now in different kind of research than the research I do, but yeah, so it can bit of a messy answer again, but then it's a vicious circle. You think, oh, I did well then, I would like to do that again. And you know, it's just the habituation of it, and a repeated behavior is what it's the behavior that starts to be repeated. And then the use disorders are where you start to repeat the behavior, where that starts to become more important. And you might, so basically it's illegal to go and buy someone else's prescription, but that seems to get devalued, or people will forget that you know, you don't have a prescription for that. And so some countries and even there can be zero tolerance whether or not you'll be, yeah, so this would be an arrestable offence really to take a prescription, or you could go down that path, you know. I don't know if anyone saw Happy Valley 3. There's a quite a good, there's a British programme called Happy Valley where they show you what the British system will do with that, but it's a good example of someone having not a prescription that wasn't meant for them and going through the procedure of being taken into a police station and booked for it. So, and then will they get overdosed or toxicity like yeah, really you can be, but there it would be different, because the opioids, you're not really seeking an opioid for as a stimulant. So that's why we're classing them as, the opioids would be more of a euphoric, not necessarily, or sort of numbing. Maybe that could be performance enhancement but the seeking or repurposing of an ADHD prescription that you don't have for another reason is probably more for their stimulatory effects. I didn't have it in the notes, but those amphetamine-like drugs are sometimes given to astronauts as well, for space sickness and things. So they are anti-nausea medications, or for people with severe seasickness, and then maybe you have to go out on a so sometimes you'll see people being prescribed those for certainly old pharmacology. They used to give them to astronauts to not get space sickness, so there's a stimulatory effects. Great, I hope that helps, and I hope I didn't ramble too much. But thank you for joining. I think, yeah, I don't know. But yeah, I guess we're a Monday morning, and in the meantime, don't hesitate to send any emails if you have questions. Thank you. So I'll just end it for everybody, should I?